Hello there, welcome. Tight or not tight? What is the target control of blood sugar in a patient with diabetes? So, our previous video, we know that the HbA1c level is the reflection of glycemic control. What should the blood sugar or the glycemic control impose to our diabetic patient? Should we have a tight glycemic control, aim HbA1c as normal as possible, being very meticulous? Or should we be more chillax of our glycemic control, does not need so tight sugar control? This video we try to answer this question by talking about 3 landmark trials in this video. First, the UKPDS, United Kingdom Prospective Diabetic Study, Advanced Trial, and the third one, the Accord trial. These are huge trials. The UKPDS 35 shows that for every 1% decrease of HbA1c, there is a significant reduction of diabetes mellitus related complication. So if there is 1% reduction of HbA1c, there is at least 21% decrease in any diabetic related endpoint complication, 14% reduction risk of heart attack, MI, 12% reduction risk of stroke, and there is 37% reduction risk of microvascular complication with only 1% reduce of HbA1c. What does that mean? That means the lower sugar, the better. The tighter the glycemic control, the less complication. In addition, the UKPDS also show, let me introduce this term, the legacy effect of earlier glucose control. Let me explain what is legacy effect. Legacy effect means if you control your sugar level in the earlier stage of your life, it will have lasting impact many years down the line. That means if your sugar control is very good now, many years down the line you will have less complication, even though many years down the line your sugar control is not that good. Conversely, if your sugar control now is bad, many years down the line you will have more complication, even though many years down the line you try to control your sugar tightly. This is shown in UKPDS, where in 1997, if you have strict blood sugar control, the benefit is affected 10 years later in 2007 with significant reduction of complication. What does that mean to your patient? You remember Madam Sue, a 40-year-old lady newly diagnosed diabetes mellitus, where her sugar is persistently high despite repeated advice on lifestyle modification. She refused diabetic medication because she felt well and she asked you to give her some more time. This is where you need to explain to her the legacy effect. If her sugar is not well controlled now, she has poor outcome many years to come. That is why tight sugar control in early stage is very important to prevent future complication, as shown in UKPDS legacy effect. And for every reduction of 1% of HbA1c, there is very significant prevention of complication. Does it mean lower sugar control? The tighter glycemic control, the better? The second trial, advanced trial, divides 2 groups of people. The first group, the intensive group, stricter HbA1c target, and the more relaxed group, standard group, where they have more lax HbA1c target. It shows that there is less microvascular complications such as diabetic retinopathy, diabetic nephropathy in the intensive group. So less sugar, the better, right? Well, the third trial I'm going to talk about is the Accords trial, and there is a small plot twist into it. Same pattern, 2 groups. The first group is 1 intensive therapy, lower HbA1c target, and the second group, more relaxed HbA1c target. They found if you control the sugar too tight, you do have less microvascular complication, but the tight sugar group has more hypoglycemia episode, which is kind of expected, but also more death. They look into this group of patients who has more death, and they are usually elderly, those who have a lot of comorbids and prone to have hypoglycemia. So frequent episode of hypoglycemia is not good for your heart and your brain. It causes arrhythmia, prolonged QT, and cause sudden death. It worsens cognitive impairment, which is already a problem in many elderly patients, unusual behavior, seizure, coma, and death. That is why tight glycemic control can be bad, especially to the elderly, those who have comorbids, short life expectancy, and prone to have hypoglycemia. So back to the question, what is the target HbA1c for our diabetic patient? Actually, it depends. That is why our target must be individualized based on patient's condition. When the patient is young, healthier, lower risk of hypoglycemia, we should aim tighter glycemic control of the target of HbA1c below 6.5. But those who are old, frail, multiple comorbids, short life expectancies, prone to hypoglycemia, glycemic control should be less tight, allowing HbA1c between 1.7 to 8. Let me end this video with this scenario. Mr. Singa is 70-year-old gentleman, underlying diabetes, heart failure, chronic kidney disease, came to your office with a HbA1c 6.5, normal. She has also a few hypoglycemic episodes at home. Is very happy with his HbA1c target. What should you do? The right thing to do is to cut down his anti-diabetic medication and allow less glycemic control because he is in a high risk group. Hope you enjoy this video.